said good morning, everybody. Much better, thank you. Today, we have our sponsors, a lot of them. We have 14 companies that sponsor today's program. We have Sandoz and Novartis, Memorial Healthcare, Viatris. They are our primary sponsors. Let's give them a round of applause. We had our community sponsors, TG Therapeutics, Mallinckrodt, Octave, FlowMed. Again, a round of applause, please. For everybody I did not mention, they're exhibitors, they're not sponsors, so I can't say their name because if they want it said, they got to become a sponsor. That's all. Just the next level up, guys, all right? All right. There's a doctor in the room that I know for way too many years. Not that he's a bad guy, but I just know him too long. His name is Dr. Brian Steingo. He's board-certified neurologist who has practiced in Broward County for almost 40 years. He recently joined First Choice Neurology in Boca Raton as a multiple sclerosis specialist. Dr. Steingo provides complimentary treatment services to patients affected by MS and related demyelinating diseases. He has participated in over 50 MS clinical trials, including phase 3 trials of Ocrevus, ofatumumab, natalizumab, fingolimod, alemtuzumab, and tolebrutinib. Pretty cool, right? So anyway, he's also the Chief Medical Advisor for MS Views and News, and I want to welcome you, Dr. Brian Steingo.
So, welcome everyone. I'm going to be doing a very important topic today, though. So you know this is my introductory slide. You know I like this slide, the land of MS. Aging and MS. Aging and MS. So all these slides, I put a lot of information in. I've done a very similar presentation to some resident groups down in Miami, and I thought I wouldn't change it very much. There's a lot of facts in here, and all of this is going to be archived. It's all going to be in MS Views and News, so all the information is there. I'm going to tell you about it. But I thought it's all very important information because aging in MS is a huge topic in MS nowadays. Very, very huge, important topic. So you've already heard about MS being an autoimmune disease. People call it an autoimmune inflammatory disease. The immune system is activated. It attacks the central nervous system, which is the brain, the spinal cord, and the optic nerve, sets up inflammation, leads to demyelination, and then leads to all the symptoms and signs of MS. Most people with MS, you can see I abbreviated it over here, PWMS. It's an abbreviation that we use, PWMS. And if you're not familiar with it before, it will be now. So PW, people with MS, to abbreviate that. So most people with MS are diagnosed between the age of about 18 to 50, 20 to 50, some age range. And most of the guidelines for how we treat MS are based on people of that range. And what I mean by that, most clinical trials for MS, as you know, extend up to about the age of 55. They go from 18 to 55. Most trials don't extend beyond 55, and they don't go before 18, because that's where the typical age of onset of MS is. And you also know that most people with MS start out with a relapsing course. By the way, Chief Stewart says I have to stand here. I like to walk a little bit or move a little bit, but I can't, because then Bill gets mad with me too. So all of us have to stand like we're fixed, like a robot. So anyway, most people with this, so 80 to 90% of people with MS start out with this relapsing course of MS. What is a relapse? You've heard about that already. A relapse is an attack or an episode or an exacerbation. I won't give it all the names because I have to fit in an extra 45 minutes here or something. But that's how most people with MS start out. You know, we used to call it relapsing and remitting MS. And what did that mean? So it meant that you had a relapse and then you had a remission. You were stable for a while. There was no sign maybe of any MS activity. No sign that we knew of on the outside. On the outside, you look the same. But we know very well, we've studied now, that if you look at the brain, there are still things that may be happening in the brain. So we prefer, instead of saying relapsing and remitting MS, maybe we rather call it a relapsing type of MS. Some people, however, start out, as you heard earlier, right from the beginning to progress. And we call that primary progressive MS. So that's someone who started from the very beginning and had a progression of their MS. Primary progressive MS maybe in about 10% of people. And then some people that used to relapse start to progress, and we have called that secondary progressive MS and some other names that I'm going to give you in a minute. About 5% of people with MS are over 50 at the time of diagnosis. So we said before, the majority of people are under 50, but up to about 5% of people are over 50 at the time of diagnosis. Now here I've put something up that you've heard about as well before, is about the progression of the disability in MS. So firstly, if someone starts out with a relapsing type of MS, they can start to progress. And there's two ways that people with MS can worsen. So if you look at on this slide over here, again, this will be safe for you to look at. The first thing that can happen is someone could have a relapse, and after the relapse, there's some worsening. And we call that relapse-associated worsening, RAW. And then there is a group of patients that will worsen independent of a relapse. They will not have relapses, and they start to slowly progress. And we used to call that secondary progressive MS. And now sometimes we call that PIRA, progression independent of relapses. So if you see that phrase PIRA, P-I-R-A, it means progression independent of relapses. Probably all progressive forms of MS, the same thing is happening we're beginning to believe. So whether you have secondary progressive or primary progressive, the type of progression that's happening in the brain is probably the same thing that's happening. Let's talk about a few things about aging and MS. The life expectancy of people with MS has increased. The overall age of people with MS is increasing, and there is a global increase. In the world, there is an increase in the prevalence of MS. So worldwide, maybe there's an increase, and in the US, we're saying about 300 people with MS per 100,000. You know, for many years, the MS Society said that we have about 400,000 people with MS in the US, but that number has been increased. Now we say there are probably about 1 million people in the US with MS, and maybe about 3 million people worldwide. But what about the age prevalence? The highest prevalence is seen in the 55 to 64-year age group. So that's what's very interesting, that the age of people with MS is increasing, and most people, the highest prevalence is in 55 to 64. Why is that very interesting? Because I just told you earlier, and you know that in clinical trials, most clinical trials end at 55. When a drug is approved, they say this drug worked for people between the age of 18 to 55. But the biggest bulk of people with MS actually in the United States are 55 to 64. And there are people that are clearly older than that, who are 80 years old now, they've had MS for many years. And people with MS live longer now. We diagnose MS earlier, we treat MS better, we recognize that they have comorbidities, we treat those earlier, and we're going to go into all that in detail. Here are some of the topics that we can discuss with aging and MS. Firstly, what about an older patient? How do we treat an older patient who has MS? If you're diagnosed with MS at age 55, do we treat you differently from someone who has MS at 18? Are there differences? There are. What is the effect of aging on MS? What is the effect of MS on aging? Things we have to think about. Then we talk about the immune system. The immune system is aging. As you age, your immune system is aging. What about comorbidities? That means other conditions that you have. An older MS patient has many more conditions to deal with than an 18-year-old MS patient. And then what about the medications? Consider all the medications that you're using. And finally, some specific issues related to aging and MS. So we'll discuss some aspects of all of these. So MS and the age of onset. We said previously that most people with MS are diagnosed between about 18 to 45 or 50. About 5% of people are diagnosed over the age of 50. In most people with MS, we said before, 90% of people are diagnosed with relapsing MS. But in older people, it's more likely, there's a higher chance that they could in fact present with primary progressive MS. An older age of onset is associated with increasing disability. So for example, on this slide, it shows you that if the onset of MS is at someone who's age 40 or 50, the risk of developing progressive MS is doubled, or if someone is diagnosed at age 50, the risk of progressing is tripled compared to people diagnosed at younger age groups. And here's the other issue with aging and MS. It's more difficult to diagnose because there are more conditions that mimic MS. So when we diagnose MS in anybody, whether they're 19 years old or 52 years old, we need to always be sure there's no other condition that is mimicking their MS, that are copying their MS. Many conditions can cause changes in the brain scan that look like MS, even migraine, or in an older person aging. Aging causes white spots in the brain that can look like MS, or Lyme disease, or lupus. There's a large number of conditions that mimic MS. And the older that a person is, the more likely it is that there is a mimic, and therefore it may be more difficult to make a diagnosis. And it's more likely that somebody has coexisting disease. So it's harder to make a diagnosis in an older patient. So it's often delayed and more difficult. So that's some of the effects on aging and MS. What's the effects of aging on MS? That's MS and aging. Effects of aging on MS. The symptoms of aging overlap with MS. As people age, people that don't have MS, as they age, have some loss of memory, some loss of balance, dizziness, visual changes. And now you have to think about what are the effects of all of these things. So what protects us from age-related changes is the brain reserve. So the size of the brain and the spinal cord are important in delaying the onset of some of these symptoms. And it's also been shown by Gavin Giovannoni that educational level, environmental aspects also will help delay the progression. And with aging, the normal repair processes that we see in a younger person are also delayed. So aging itself can have effects on MS. MS reduces the cognitive reserve. If someone has MS, there is some damage to some brain tissues, and so as they get to an older age, they have already lost some of their brain reserve. Look at the brain volume loss as people age is normally about 0.1 to 0.3% per year. In people with MS, the brain volume loss is 0.7 to 1% per year. So people with MS have double the loss of brain volume. And all of our drugs now, when we look at them or we do studies, we're trying to slow down the progression of the brain loss or the brain atrophy. This is something that we're looking at more and more in our studies to try and slow that down. What about the immune system? So the immune system ages. The word they use for that, and I put it in here in case you read it, it's called immunosenescence. Just the same as you hear of adolescence, we have this aging of the immune system called immunosenescence, which is the decline in the immune system. So as people age, what happens? They have more frequent infections, or their response to infections is reduced, and there's a higher rate of cancer. These are all parts of aging because our immune system is not as powerful as it used to be. So people with MS have that same risk. But in addition to that, you're taking drugs for your MS. Where do these drugs work? You heard about that earlier. A lot of them are working on the immune system. You already have an immune system that is more fragile, and now these drugs might have effect on the immune system. So it's very important as well to look at the drugs and consider the drugs very carefully in older patients. What about comorbidities? Very, very important group. So people with MS are older, they have associated diseases. Let's look at some of these. What do these comorbidities lead to? And we've already said that. Because of them, you have diagnostic delays. An older person may present, for example, with tingling, and they might be diabetic and have numbness and tingling. They might be dizzy. Other conditions that we have to think about. And so what about disability progression, the effects of aging added to their MS? Health-related quality of life. Progression of changes on the MRI scan. With normal aging, we see white spots on the brain. Other conditions, diabetes, high blood pressure, heart disease cause white spots on the brain. Which white spots are from MS, which are from aging. So all these things we have to constantly be evaluating in our older patients. Let's look at some of the comorbidities that can occur with MS. The first group I put here was other neurological conditions, memory loss, gait dysfunction. All of us have seen older people that have memory loss. Other conditions, Alzheimer's disease. Alzheimer's disease is common in the general population. If 5% of people get it in the general population, that means 5% of older MS patients will get it too. So we have to be attuned to this, not to blame this, and all of you know that. Don't blame everything that happens on MS. Let's always be sure there is no other condition that may sometimes be a treatable condition that is causing the symptoms that someone has. And now this very important group, number 2 here, cardiovascular and metabolic disorders. It has been shown that people with MS have a higher risk of cardiovascular disorders. Why, we don't know. So people with MS have a higher risk of heart disease. They have a higher risk of strokes. We don't know why that is, but that is a fact. And it's been well studied in many studies. We don't understand it. Could it be genetic? We don't know why, but that is a fact. And when I've been stressing, as Dr. Coppola said earlier, about Eating healthy for MS, it extends to this group too. If you have high blood pressure, heart disease, you have to have a healthy diet and pay attention always to your diet. It extends into this group. Cardiovascular conditions, commoner in people with MS. Interestingly, there have been a study, so we know that people with MS have these cardiovascular diseases, important to take care of lipid elevations, to maybe use a statin when indicated, and it's interesting that some people have actually studied statins in the treatment of progressive MS. So this is ongoing work. What about musculoskeletal diseases as people are aging? People with MS have trouble walking. They have balance problems. Well, you could have underlying other conditions. You could have arthritis in multiple joints, back pain, knee pain, ankle pain, hip pain. Multiple arthritic conditions may occur. And what's the effect of MS on those? There's interaction. If someone has MS and they're not walking properly from their MS, maybe they have a limp, it affects the mechanics of their gait, it increases their orthopedic problems. And they might just have underlying arthritis, you add that to those problems. So orthopedic problems, musculoskeletal problems are very common. In addition to that, you have other situations, osteoporosis, that may occur in people with MS because they've had more steroid. Sometimes when people have trouble walking and bone problems, they actually have a fear of falling that in itself can affect their gait. So again, we're seeing a whole bunch of interactions that we constantly need to be thinking about. What about psychiatric problems? And this particularly applies to things like depression and anxiety, which we have to attend to, which are more common as well. Sleep disorders. Sleep disorders may commonly occur in people as they age, and maybe for a variety of reasons. Sleep is a complex thing, so sometimes people may have what we call a primary sleep disorder, or the sleep disorder can be due to some MS features. For example, their bladder. They might wake up multiple times at night because of their bladder, or they may have muscle spasms that wake them up. So MS can affect sleep. But in addition to that, other sleep disorders such as sleep apnea are more common in MS. So sleep disorders can be a big problem to deal with. How about the bladder? This is specifically mentioned some bladder problems. Like in males, also to think of the prostate, not just to blame a problem on the bladder, but on the MS, but rule out prostate problems, or in females to have weak muscles, pelvic floor muscles. Gastrointestinal problems can occur with aging and with MS. MS can affect both the upper gastrointestinal tract. People can have a slowing of their stomach muscles. It's called gastroparesis, where the stomach will empty very slowly, or they can have lower intestinal problems, constipation, lack of control, incontinence as well as with the bladder. And then the final comorbidity that I've listed over here, you can see, is cancer. That's somewhat been evaluated. There was actually a study, people said maybe people with MS have less cancer. But that's not the case. It doesn't, for the most part, there's no direct link. But we also have to think of the drugs. Some of the drugs have been described as maybe causing some increase in cancer risk. So this is something that we always have to attend to. And when we start certain medications, also in our patients, to make sure that they've done all their cancer screening. For example, seeing the dermatologist, doing the colonoscopy, doing the mammogram, doing all the appropriate screening before they start their medication. So this is a summary over here of the comorbidities and multiple sclerosis. There is evidence that many additional factors impacting brain function and brain health can exacerbate, can interact with smoldering MS, resulting in more rapid disease worsening. I spoke to you earlier about progression independent of relapses, so-called PIRA, and the other terminology that goes with that is smoldering MS. It means that there's some low-grade inflammation that's going on inside the brain. We spoke even earlier about relapsing and remitting MS, that people have used the word remitting MS. When you think of cancer and you think of remission, you say, well, there's no sign of cancer. And that's why we took away that we don't like to use the word remitting for MS, because there may still be some inflammation that's going on in the brain when we see people getting worse. There's some smoldering inflammation. It's low-grade inflammation. It's in the brain. And a lot of the drugs that we use that are working on the outside, on the immune system, are not getting into the brain. They're not having a direct effect on the brain. And this is where a lot of our new drugs that we're hoping are going to be drugs that penetrate into the brain and can affect the smoldering MS. You know, we have many drugs for MS now. We have over 25. Miraculous, isn't it? When you think the beta serum was approved in 1993. But the majority of these don't get into the brain itself. They're working on the immune system. And so more and more we're trying to find smaller molecules, drugs that are smaller size that can actually penetrate into the brain and can affect the immune process, the inflammatory process in the brain itself. Other factors that are very important with aging, and this is a whole discussion in itself, is what about other factors for general health, which you've heard earlier: exercise, and paying attention to diet, healthy eating, smoking, avoiding excessive amounts of alcohol. And then there are social determinants of health. Some of this I'll mention again in a minute. Medications. You see here I wrote the anticholinergic burden. I'll explain more of that to you in a minute. Poor sleep and comorbidities. So there's a whole lot of things that are happening, and we have to pay attention to all of them, because all of them can affect the quality of life. The quality of life of an older person with MS is not just the MS. It's often other things, such as these things: poor diet, lack of exercise, and some of these other comorbidities that we've been over. It's a hugely important topic to look over. And therefore, as it says here, a holistic approach is necessary. Pay attention to all the other factors. How is your diet? Are you exercising? You know, I ask those questions every time, and because they're all important. And now another very important topic: aging and polypharmacy. What does polypharmacy mean? It means someone's taking many medications. And they're taking medications for what reason? For MS. Maybe. For MS symptoms. And you're going to see a list of those in a minute. Or for other conditions. And by the end of the day, somebody could be on 20 medications. How do they all interact? Do you know? Sometimes the pharmacist will tell you, sometimes not. So people may have other chronic diseases that could have multiple different doctors, multiple prescribers. Does each doctor look at every medication you're taking? Or you may have multiple pharmacies. This comes from specialty, this comes from here, this comes from there. Then drug formularies and cost changes over time. The number of medications has increased, and sometimes there's a tendency for people, every time there's a symptom, and there are people that like every symptom, they want a medication. So you end up with a bunch of drugs. And then the common dosage of a medication might not be the right dose for a particular individual. They may require, for example, age-adjusted doses. And finally, is there adequate monitoring and follow-up? It's important. So here's a list of some of the drugs that are used to treat just the MS-associated symptoms. Now, this is not drugs that are treating your hypertension or your heart condition or your hyperlipidemia or COPD or any of a number of conditions that someone might help. This is drugs we're using to treat your MS. Look at this list. Could you imagine the interactions that are going on? And we always need to be looking at this. So have a look at fatigue. So for fatigue, we could be using amantadine or stimulants. What can stimulants do? We try and avoid them if we can. They can cause the heart to race. They can cause headaches. They can cause dependency. So these medications for fatigue, depression, many antidepressants. Now, previously I mentioned briefly in passing something called the anticholinergic effect. It's very important. Many drugs that are used have anticholinergic effects, particularly two groups of drugs that you should be aware of. The first group is antidepressants. Some antidepressants have anticholinergic effects. That's the way they work on this pathway, anticholinergic pathway. And then there are antidepressants and a lot of bladder medications that are used as well, including common ones like oxybutynin, have anticholinergic effects. Older antidepressants especially, and even some of the new ones have anticholinergic effects, like amitriptyline, Elevol, and some of the newer ones also have some anticholinergic effects. And the effect of anticholinergic effects has been shown to worsen memory over time. So people sometimes are on these drugs for years, and they contribute to memory loss. So it's important to know about some of these medications in long-term use. And then there's a list of drugs for spasticity, including sometimes using Valium or other drugs. They can cause drowsiness. Many drugs for pain, gabapentin, etc. Bladder medications, constipation medications, dizziness medications, cognitive medications, tremors, walking. We have one drug for walking. So there are many different drugs that we have, and we always have to be paying attention to how these medications all interact. So it's just a very important thing to look at. So we have a form that sometimes people fill in our office, and it says, is there any change to your medication? It especially asks people, what are your medications? Sometimes people will write it, and sometimes they won't write it. They'll write unchanged or the same. I mean, these are not helpful because then we have to look at all the medications. So it's very helpful if you go to your visit and you have an up-to-date list of your medications that you present to your neurologist when you walk in the office, and you sit there and we can look at the list and you make a list. The ideal thing is, for your visit, that saves a lot of time and makes your whole visit so healthy, is to say, this is my medications and this is what's new. Since last time this was added, but here's my list. It's very helpful for you and for us. Aging and MS, some specific issues. Here are some specific issues that we look at. Cost, and you heard about this before. I can't say any more than what Dr. Capolo just told you about. Cost and insurance coverage. These medications are expensive. Many times our medical assistants are calling and fighting with insurance companies. Frequently, the drug's not approved. We have to get authorization to get a drug approved. Now, there are some good things that have happened with MS. We have finally, beta-seron is now 31 years old, and we actually have generics in the last few years, which actually is fantastic because in the past, you hear about the prices of these drugs. Drug X, how much? $100,000 a year or some ridiculous thing like that. Well, guess what? You can now get generic teriflunomide. Teriflunomide, which is Aubagio. Is it the most powerful drug? No, it's not the most powerful drug. But it's a working medication that's got some role to play in MS. You can go to Walmart and get it for $10 a month. That's amazing when you think about the price of all these medications from the past. So some things are moving. There are some generics. Hopefully, they will have more of those available. Aging and MS, lack of clinical trial data. We spoke about that before, that most of these trials have patients that are age 18 to 55. Now, some of the trials that we're doing now, which are for patients with secondary progressive MS or MS that's showing some slow progression, some of them will extend to 60. It's rare that they go beyond that. But we still will extrapolate. If a trial goes 18 to 55, it doesn't mean we can't use it in somebody who's older once it's approved. We still might do that. But we have few drugs, as you know, for progressive MS. Still only one approved drug is Ocrevus for primary progressive. There was some mention earlier about some of the BTK drugs, and the BTK drug that is of excitement right now is tolebrutinib, which is a Sanofi product. Tolebrutinib was studied in two types of patients. It was studied in relapsing MS, and in relapsing MS, the comparator drug, the drug they compared it to was Aubagio, and the results did not show any benefit over Aubagio. It worked. It did work, but so did Aubagio. Aubagio worked too. So we said, well, it's no better than Aubagio. However, in secondary progressive patients, tolebrutinib did slow down the progression in those patients. So this is exciting now. The company has to gather all the information and present it to the FDA. And with a little bit of luck, we may soon have a drug that's approved for secondary progressive. But I don't know if the FDA is going to be happy with the data or not. We never know that. It is a drug that will require monitoring because it did have some liver effects. So it's going to have to require quite a lot of liver monitoring. But it is a drug that may be approved for secondary progressive MS. And then there are other drugs in clinical trials now that are also being studied for secondary progressive MS that have age limits that are a little bit higher. And then patient health literacy. Well, what does that mean? That means generally in older patients, they obviously are not as adept at social media and telehealth and using all modern stuff. Patient communication may be harder to reach patients. Limited access to procedures, limited access to get around, transportation, personal resources. Remember, sometimes people have had MS for many years. They've been struggling for many years. Their income, they could be struggling more. So there are some problems we see in older people that we have to deal with and get help from social agencies, MS Society, family, friends, and community people being alone. The neighborhood, transportation, trying to get transportation, which is something that really is an ideal situation for telehealth, but people often struggle with that. So these are some some specific social issues that we see with aging as well. And this is like the final wrap-up of everything. And so, you know, my favorite slide that I have to show every year is this one here about the land of MS, and I just want to show you how aging is incorporated into the land of MS. If you look at the very bottom, in the middle you see the land of MS, the control tower as we call it, which is where the team of myself and yourselves is located. And then at the bottom on the left-hand side you see social support, which is important for all our older MS patients too, the support that they get. And the better support that someone has from their family, the better that they do. So people that have good family support do much better. It's just a fact. Maybe it's obvious, but it's a fact. It's very important to have some good support. The self-power tower, doing some things for yourself. We can give you advice, but doing some things for yourself. And then on the bottom on the right, wellness, the general health, what I've called the health bank or the mind bank. And that includes things like exercise and diet and all the things that people do for themselves. And then just to all the rest of it over here is managing the symptoms, and then the research center, managing research, new ongoing clinical trials, looking at dietary measures. All these things are all equally important in our older MS patients as they were in MS patients in general. So I think that concludes the section on aging and MS. Now, I think that's enough. Stuart, I think if you look at the agenda, Stuart had thrown in a few little extras there, but I don't know, on spasticity and things like that. But that's I think we've done some of that discussion earlier. So I think this is an important enough topic to stop.
You're stopping? You still got 3 minutes and certain seconds there. I'm joking with you. Thank you very much, Dr. Steingo. All right. Who's got questions?
Back here.
All right, let's start there.
Hello, Dr. Steingo. Back here. So, with regards to the blood-brain barrier, are there any medications in development or down the pike that are coming up?
So the question is about the blood-brain barrier. The blood-brain barrier is like a gateway between the brain and the circulation. For example, you could say over here that we're in the circulation, and there are doors over there, and the hallway out there is the brain. So we're on the blood side, and between them there's a barrier called the blood-brain barrier, and it restricts entrance of things like chemicals or certain types of cells into the brain. So it's called the blood-brain barrier. A lot of the drugs that we have don't cross it. For example, they're big molecules, they cannot cross. And their effects are on this side, their effects are here. They're working on the immune system and changing the immune system. They're not having a direct effect on the brain on the other side. So what we need is we need smaller molecules that can penetrate into the brain. And the answer is we already have some. Some of the drugs that we have are smaller molecules. Teriflunomide that I mentioned earlier is a smaller molecule. It can penetrate into the brain. Mavenclad or cladribine is a smaller molecule. It can penetrate into the brain. And so yes, the drug that we mentioned to you, you've heard a few times mentioned today, tolobrutinib, it can penetrate into the brain. So the BTK drugs look like they probably could penetrate into the brain and have a direct effect maybe on certain inflammatory cells in the brain. So we already do have some smaller molecules that can penetrate into the brain. And so we'll maybe work a little differently, not only work on the outside, not only work in the circulation, but also work in what's happening in the brain itself.
Hi, doctor. As far as your age of diagnosis, I was diagnosed at 47. However, I can trace this to 26 years before. If there had been a doctor that had called it when I was 21, he would have called it MS, but there was not a doctor that did it. So was my diagnosis at the age of 47 or 21? I've never known from when to gauge the progress of of anything that happens to me?
I mean, so many people that present with MS, you go back in their history, they've had symptoms before that. So they'll come in with their first episode. It might be optic neuritis, for example, or something. And then, you go over the history and they say, well, 10 years, you always ask, have you had any symptoms beforehand? And yes, sometimes they have, even 20 years ago, and it wasn't diagnosed. And that was usually probably the beginning of their MS. And if their first symptom was 10 or 20 years ago, now they get another symptom, it's probably pretty good that you went so far between relapses. Because we know with MS that the closer your relapses are, the worse it is for the prognosis. I mean, if somebody has 2 relapses in their first year, their outlook is generally worse than somebody who has 2 in 10 years. Prognostically, the closer they are and the worse they are, the worse it is. So that's usually good. If your last relapse was 21 years ago and you haven't had one for 20 years, you're usually going to have a better prognosis. I would say in the situation you're describing that, in fact, if it was 21 years before that when you were 26, that was probably the onset of the MS. And then for many years you were lucky and had nothing until you were 47. But the age of diagnosis is 47. MS, the one thing about MS you all know is that it is unpredictable. Unpredictable. That's the only thing about it that's predictable. Is it's unpredictable. So, yes, unpredictable. And then what happens? So we've seen people that had an episode 21 years ago, then they present at age 47. And at age 47, they could have a mild episode or a severe episode. And then at age 47, the MS manifests maybe in an ugly way. So it's unpredictable what can happen. But you would start the treatment at that age of 47. And some people at age 47 will now present with a secondary progressive form of MS. They will come in and start to be slowly progressing. They've had no known relapses for 20 years that they know of, but they're things that have been happening in the brain. They have not really been in remission. But they've been doing so well on the outside that you haven't been seeing what's going on in the inside. On the outside is the tip of the iceberg. What's happening inside? You haven't been seeing that. They haven't been followed. They've been feeling great. So they haven't had scans. Meanwhile, if you look at their scan now compared to 20 years ago, it's clearly worse. And you haven't seen that happening. The invisible symptoms might have been going on. Things have been happening that we haven't seen. But obviously at age 47, we're going to sit up and take notice finally.
I'm hoping that I understood what you said correctly. You said that there were so many symptoms and they have a medication to go along with it, and those could affect your cognitive skills. Okay, so what's the alternative?
This shows you all the drugs. So it depends on it. So what we said, specifically what I referred to, is the group of drugs called anticholinergics. Anticholinergics are drugs that work on that particular pathway, the anticholinergics. And those drugs are 2 families of drugs, particularly that people with MS or other people take for other things. Antidepressants, Elevol. I'm sure there's people in here that have been on Elevol, amitriptyline, some of the other antidepressants, bladder medications, oxybutynin being, for example, one of the commonest ones, and some of the other bladder medications that have those effects. So then what you have to do is try and wean people off those medications and put them on alternative medications. So for example, for your bladder, we want to get you off oxybutynin. Here's a good example of a bladder medication that doesn't have anticholinergic effects, and that's Myrbetriq, or the newer version of that, Gemtesa. I mean, those medications do not have anticholinergic. You could take that medication, for example. So that's for the bladder. And then for antidepressants, we're trying to get you on an antidepressant if someone needs one that maybe doesn't have the anticholinergic effects.
So when I go in to see my neurologist, bring the list of medications that I have that are on here, and we'll see if we can come up with alternatives.
Yeah, we would always try. Sometimes it's hard to find alternatives. I mean, for example, amitriptyline, I've seen people that, they've been on for 25 years for sleep. They take it every night, 10 milligrams, 25 milligrams, whatever it is for sleep. Every night they take their amitriptyline. And after 25 years to try and get someone off a drug is not easy. But we try. We'll always try, and not always be successful, but we'll certainly try. Especially if they've got memory problems. Then we really want to get them off the medication.
Yes, hi, doctor. I want to go back earlier when you started and you were saying something that in addition to them noticing that patients are being diagnosed later in life versus, the typical 20 to 40-year-old, now it's, between 55 and 64. But you're also saying that the longevity of MS patients has expanded, like they're living a little bit longer than prior. And could that be just a direct correlation because now, more people are on DMTs, they're on treatments, they're on, could that be just a direct correlation of that? Or they're just trying to they're still trying to find out what's causing the longevity that wasn't there before?
And somebody had asked a question earlier, I think of Dr. Capola too, but, I think they asked you that, yeah. I mean, people with MS live longer because they're treated for a number of reasons, and I think the lifespan in general may be improved when we take better care of people. Firstly, we diagnose people earlier, but more importantly, we have medications that we can put them on now. And so from when I started practicing compared to Dr. Capola started practicing, it was like day and night. When I started practicing for MS, there was, you know how many drugs there were for MS? Zero. And people with MS used to arrive in the emergency room or the hospital, if you were on call as a resident in the neurology section, nobody wanted the MS patient. Because it's very hard to look someone in the face and they say, what can you do for me? And you can say, nothing. I can give you steroid, but there were no drugs. So now we have drugs, and the drugs have significantly modified the course of MS. So we treat the disease. Number two, we treat the symptoms. And then we help lifestyle. We stress to people about exercise and healthy eating and all those things. And that's why the lifespan of MS patients has definitely improved over the years. So that's definitely a factor. We recognize comorbidities. So those are some of the things. The things that people with MS have that we have to be particularly attentive to as they get older are falling. Once you stress the gait, people with MS have a higher risk of falling always, which causes head injuries and other fractures. Infections, sepsis, urinary tract infections. So we pay particular attention to those because those shorten life. But other than that, definitely the lifespan has improved because of all the other factors that we deal with.
I get hello, doctor. Two questions. The clinical studies that go from 18 to 55, say there's 1 million people here in the U.S. with MS. Is there a profile? What the age groups are after 55? Like you're saying the majority of people 55 and less have MS. What about over 55? Is there a majority of people there? And at what age maybe take them up?
If you go back to clinical trials for MS, let's talk about the common trials. The first drug approved was beta-seron in 1993. When they picked the patients in the age group, they said, we're entering patients from age 18 to 55. Now, why would they do that? Well, because we just said before, patients that are older 55 have comorbidities. So if you're giving someone new drugs, you want to eliminate as many other variables as possible, and older patients have more variables. They could have diabetes or heart disease, orthopedic problems, all this whole list of comorbidities. And so they specifically said most MS trials to this day still for relapsing forms of MS go from 18 to 55. That said, once the drug is approved, between you and your physician, your neurologist, you can make a decision to take a drug. Let's take Ocrevus, for example. Ocrevus was studied from 18 to 55, but there are people that are in their 60s that are taking the drug if they have progressive MS. So we can then, this is a decision between you and your physician, but typically the trial has to have limitations. And they picked 18 to 55 for most drugs. Now some of the trials that are being done now on drugs that cause secondary progressive MS, in some of those studies, they're extending the age a little bit. It's very rare to be 65 to about 60. And it's just FDA decisions and drug company decisions to make the study as clean as possible and to eliminate comorbidities. I mean, if you have a 62-year-old person, the chance that they're diabetic or have hypertension or some other condition is much higher than a 42-year-old. And if a complication happens, is the drug, it makes it much more difficult to evaluate. That's why they've got that range of 18 to 55.
So if an older person hasn't had a relapse, do you say, don't take it anymore? Say they're 70 or 80 years old. Is there a point where you say, not necessary to take your MS medication anymore?
This is a huge topic in MS too. MS and the discontinuation of drugs, which follows through with MS and aging. There have been several studies that have been done in discontinuation of treatment in older MS patients. And again, for this, the cutoff age that they used was 55. And so in several of the studies that they've done, they've taken a cutoff age of 55 and said, let's look at our patients of 55 and above. And the Rocky Mountain Center is one of the centers that have done most of the study, John Corboy. And they took patients over 55 and they said, now we're going to randomize our patients. That means you put their name in a hat and either you stay on your drug or you come off your drug. You don't get to choose. We choose. And then we see how you're doing after a little while. We're going to see, is it okay to take you off your drug? Are you safe to come off the drug? And what they said at the end of this initial study, by the way, the study was slowed down considerably because of COVID. Otherwise, we would have had results a long time ago. But when they finally published the study, what they essentially said is it's inconclusive. We're not sure. That some people come off their drug and they look fine, but some people have come off their drug and they have had some progression. More progression seen like in new MRI things than a progression of their symptoms. So it looks like if you have an older MS patient, let's say 65 years old, and they've been stable for 10 years, they've had no new relapses. They've had no progression. No progression important, no change, no relapses, no progression. MRI scan is stable, the exam is stable. Everything that we look at is stable in that patient. Then there could be discussion about coming off their drug. Now, we're hoping to have other things to help us that earlier Dr. Coppola mentioned, like biomarkers. What is that? That is a blood test, maybe. So you can do blood tests for many conditions to tell how somebody doing. Take a statin, let's see your cholesterol. Oh, it's good, you're great. We don't have a drug for MS like that. No, we don't have a blood test for MS like that. We're looking for them. We're getting some biomarkers established. NFL right now, probably the most important one, but we're trying to establish stuff with biomarkers, biochemical substances. Maybe in the future that will help us measure how somebody's doing with their MS. There was one other study that has slowed me down a little bit in this. That was a study done by the New York Consortium. So in New York, a bunch of these MS centers got together, the whole consortium of New York MS centers, and they published their results. And what they found is that after stopping people's medication, one third of patients progressed, and 2/3 didn't. So is the glass half full or half empty? I don't know, but quite a few patients progressed. The other thing about progression is also depends on the medication you're taking. And maybe this is intuitive. The more powerful the medication the people were taking, the worse that they did. And if they were taking milder drugs, maybe like something like Copaxone, for example, they had less progression. Maybe that's because people on a milder drug have milder MS. In addition to that, some drugs like Tysabri or Gilenya, fingolimod, are associated with rebound. If somebody's on a drug like Tysabri, it's very tricky to take them off the drug. There's a high risk of rebound with some of those drugs. So I would say that we don't have any general rule right now. It's a very individual thing for different people that we have to evaluate, each case by case.
Is brain shrinkage worse in aging MS patients than in the general population?
I mean, yes, it is. I mean, brain shrinkage, as we said before, occurs let's see. Yeah. Brain shrinkage in the general population, the rate of brain shrinkage is about 0.1 to 0.3% per year with aging. And in MS patients, it's about double that. So yes, the answer is that in MS patients, we do see brain shrinkage at a higher rate. If you see a younger MS patient, they're going to have more atrophy than their peers, more atrophy than you'd expect, more atrophy than their peers, yes.
Thank you. Another question online is, they've heard that lifespan is less in people with MS than the general population. With all the new drugs, does that still apply?
Yeah, we kind of replied to that, answered that already here. We said, yes, I mean, in general, over the years, people with MS have been said to have lower lifespans for a variety of reasons, but that's certainly been improved. I'd say in most people, you can anticipate a fairly normal lifespan with all our modern medications, attending to infections and preventing risks like falling. We certainly have improved that considerably, and I'd say that the lifespan has definitely improved compared to what the old textbooks of 20 years ago used to say that people with MS have a shortened lifespan.
Can a patient with secondary progressive MS be considered NEDA?
Say that again, Joel?
Can a patient who has secondary progressive MS and has no ongoing lesion and no ongoing activity, can they be considered to have NEDA, to have met the standards for NEDA? No evidence of disease activity.
Yes, Well, no evidence of disease activity. So the question is of this term NEDA, N-E-D-A, which is no evidence of disease activity, which comes from also, is a term we use in clinical trials, which means that a person has no relapses, no progression, and no changes at all in their MRI scans. So are you saying, can a person with secondary progressive?
Yeah, I think that's.
If you're secondary progressive and you're not having ongoing activity, can you
But-
apply the term NEDA?
No, I mean you have progression,
How do
right?
you know?
They have secondary progression. You're saying, right?
Well, they're
They're
not
progressing.
relapsing.
I mean you're measuring progression. Maybe you're not measuring. They're having no relapses, but there's some form of progression. Whether it's something in terms of their walking or their cognitive functions, there's some progression that's going on. So it's not NEDA.
Let's thank Dr. Steingo. Thank you. Great, thank you. Awesome, thank you. So you made it to the end of this program, and I do thank you very much for that. You know, for those that are online, we thank you also. Be safe, everybody. Do what you got to do in life, all right? Don't let MS stop you. Don't let MS stop you. Take care. Have a great day.